So I will discuss with you Anesthesia INI May 2024 questions. So there were 6 questions from anesthesia, and most of the questions were very predictable and they could be easily solved, and we could have a very good strike rate of 100%. So the first question was on the airway device, that is our supraglottic airway device, laryngeal mask airway. The question was a very simple question. It was asked, which is the second generation laryngeal mask airway? And the options were laryngeal mask airway ProSeal, that is LMA ProSeal, AMBU LMA, intubating LMA, classical LMA. So to answer this question, we need to understand what is second generation LMA and how this word came into origin. You know, Dr. Archie Brain, he was the person who designed LMA. So Dr. Archie Brain, he designed LMA, right? And he designed LMA for as a rescue airway device in difficult airway situation. That was in his mind. He came up with the first generation classical LMA, right? At that time, the generation word was not there because this was the only first supraglottic airway device which came into existence by Dr. Archie Brain. Now, classical LMA was a very good airway device. It was very fast in securing the airway. It was easy to secure the airway with this device, and whenever there was a situation when they couldn't intubate the patient, this device was very helpful. But one major demerit of the device was that aspiration could not be prevented. Aspiration was not prevented. So it didn't form a good seal over the glottic opening to prevent aspiration. The seal was not good enough, especially during positive pressure ventilation. So Dr. Brain, he came up with an improvised version that was second generation. Then the term came second generation LMA, second generation laryngeal mask airway. And it was ProSeal LMA. That was also designed by Dr. Archie Brain, ProSeal LMA. He made a lot of changes in the classical LMA, which improvised it to ProSeal LMA. So classical LMA became first generation. That it became first generation, and all the airway devices, supraglottic airway devices resembling classical LMA became first generation supraglottic airway device, and all the LMA airway devices which had the benefits of ProSeal, similar benefits as ProSeal LMA, was second generation laryngeal mask airway or supraglottic airway device. So what are the difference between first and second generation? First generation, what are the example, and second generation supraglottic airway device. First generation supraglottic airway device, the prototype device, classical LMA. Second generation, ProSeal LMA. Now let me make just a line diagram of classical LMA. It had a mask, right? Mask and a tube attached on the other end of the mask. This was the ventral side, which had the opening with the ridges to prevent epiglottis to fall on the opening. It had pilate balloon system to inflate the cuff. So it had cuff. Okay. So this was classical LMA. Now this was improvised into ProSeal LMA. Now this classical LMA had one airway tube. It has one airway tube, right? What was done in ProSeal LMA, right? Two tubes were created, one for the airway and another side-by-side tube which was attached to the airway tube, a gastric tube, which ended on the tip of the cuff. So here also there was an opening provided because this tip for any supraglottic airway device would rest on esophagus. So if there was a tube with an opening on the tip, we could even put Ryle's tube through this and we can deflate the stomach. Even what other things were done, that cuff, which was just one in the classical LMA, two cuffs were provided, a dorsal cuff and a ventral cuff. So what benefits these structural changes gave ProSeal LMA? The major benefit which was given, that classical LMA was not forming a seal good enough to prevent aspiration. ProSeal LMA was comparable to ET tube in preventing aspiration. So this was comparable to ET tube in preventing aspiration. So this was comparable to ET tube in preventing aspiration. Got my point? This is your ProSeal LMA. ProSeal LMA. Comparable to ET tube in preventing aspiration. Got it? Okay. Now guys, what are the examples of second generation LMA? LMA ProSeal is the clear-cut second generation LMA. Ambu LMA is first generation LMA. Now this Ambu LMA is like LMA Classic, just made by the Ambu company and disposable single time used. Intubating LMA was a special LMA which could help us in intubation. This was not given a generation, first or second generation. So it was a generation less. Some books write it is second generation, but actually if I have to choose for the second generation, LMA ProSeal would be a better answer. So it was not given a generation. And classical LMA is a clear-cut first generation LMA. Okay. So what are the important things that we need to remember for laryngeal mask airway? So laryngeal mask airway, which was designed by Dr. Archie Brain, it is a very good airway device, easy to insert. You just have to hold it at the cuff and the tube junction, and with your index finger, you have to make the patient in morning sniffing position with the other hand, and with your index finger, you always hold it in the dominant hand. You just push the LMA towards the posterior pharyngeal wall, flattening it on the posterior pharyngeal wall, and just you push it and down, 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 down till you feel the maximum resistance. Now you cannot push it any down. You take the hand out, inflate the cuff, and it forms a seal over the glottic opening, and the tip goes into hypopharynx on esophagus. So it is very easy to insert. It is fast to insert. It is less invasive. And third point is that laryngeal mask airway, which is fast to insert, easy to insert, is less invasive. And a major benefit of laryngeal mask airway is that anyone can insert it. You don't need much expertise to insert it. So in, let's say, cardiac arrest patient also, when it was difficult to intubate them, LMA was being used. But what major issue of this device was that it could not prevent aspiration. Could not prevent aspiration. So this could not prevent aspiration was little bit minimized by second generation LMA. Now another few more devices I want to tell you in second generation LMA. Now first generation and second generation. In second generation, I want to tell you we have ProSeal LMA, as I told, iGel airway, right? The LMA Supreme, which also has two tube, LMA Supreme. Whenever you see two tube, go for it as an answer, second generation. If there are two tubes in the supraglottic airway device, it is second generation. Got it? Okay. Now next question. Which of the following is induction anesthesia agent of choice for pediatric age group? So for induction agent of choice, blind answer, sevoflurane. Sevoflurane, best agent for induction. Now what are the things we need to remember about sevoflurane? This is the best agent for induction, both adult and pediatric, if I am using inhalational mode of induction. Now sevoflurane has blood gas partition coefficient 0.63, which makes it a very fast agent. It has a very good smell, which is easily tolerated by the patient, and their acceptance of sevoflurane is very good. Now sevoflurane increases intracranial pressure minimally. Increase intracranial pressure is less than other inhalational agent. So this is best for neurosurgery. So for neurosurgery, sevo among inhalational is agent of choice. For pediatric, it is the inhalational induction agent of choice, right? These are the points of sevo we have to know. Now let's say DES. DES is faster than sevo because it has a blood gas partition coefficient less. But DES is a respiratory irritant, cannot be used for induction. Cannot be used for induction. So we cannot use it for induction, desflurane. Okay, but DES is otherwise good agent with low lipid solubility, lowest lipid solubility. Desflurane has lowest fat solubility, right? So it doesn't accumulate in the body at all. So you can give it for long duration without accumulation. So this is agent of choice for maintenance in your bariatric surgery, in old patients, in prolonged duration surgery, right? It is also good agent for patient with renal and liver dysfunction, right? Because it is not metabolized, renal and liver dysfunction, because it is not metabolized at all in the body. So it is also a good agent, but just for maintenance. We don't use it for the induction. Then is halothane, now obsolete. But halothane has one benefit, it has a good smell like sevoflurane. So if sevo is not there for induction, if sevo is not present for induction, which is the other agent I can use? I can use halothane, right? Halothane is good to be used in children, because a major problem of halothane is halothane hepatitis. This halothane hepatitis is seen less in children, less incidence in children. So kind of halothane is good agent if we use it in children with care, okay? But halothane slowly is becoming obsolete. Isoflurane is another good agent, but the issue is it is also a irritant. So we should not use it for induction, right? But iso is a very good agent. It is a cardiostable agent. Even sevo and desflurane is also more or less cardiostable agent. For isoflurane, what we need to remember is isoflurane is a good maintenance agent, and this is agent of choice in cardiac surgery, right? So we are very commonly using it for cardiac surgery, isoflurane. Overall also it's a good agent which we can use for number of other surgeries as well when other agents like sevo and desflurane is not available, okay? So these are the things that we need to know about these agents, okay? Now coming on the third question. Third question asked was again a very expected topic, CPR. They asked about the points favoring the high quality CPR. So first option was 100 to 120 compression per minute. That's a correct option. 3 to 4 centimeter compression is required. That's an incorrect option. So this is the answer for the incorrect step. Compression ventilation ratio is 30:2, right? Adequate chest recoil always. So guys, you need to remember on your tips the points for high quality chest compression. High quality chest compression. So what are the important points for high quality chest compression? Number 1, push fast. So what should be the speed? 100 to 120 per minute. Then push hard, that is between 5 to 6 centimeter. Allow complete recoil, right? Then fourth is your just minimum interruption in chest compression, minimum interruption in chest compression. So chest compression, there should be minimum interruption. And fifth, just adequate ventilation. The ventilation should be just adequate. It should not be more than, let's say, 10 breaths per minute. So these are the points for high quality chest compression. Remember, so here the compression depth is not adequately written. This is the compression depth maybe for infant, okay? We need to compress at least between 5 to 6 centimeter in adult, okay? Next, patient was planned for surgery under general anesthesia. In induction phase, rocuronium was given, but anesthetist didn't got success in intubation. So he wanted to reverse the patient because he was not able to intubate. In that case, what agent should be used? Well, which is the agent which will cause immediate reversal? That would be your rocuronium. So that would be your Sugamadex. Remember, Sugamadex is the direct reversal agent for rocuronium. Now, just understand about Sugamadex, this molecule, Sugamadex. Well, this is a reversal agent which is nowadays recommended by the different societies to be used for reversal of neuromuscular blocking paralysis. Sugamadex is a direct reversal agent. Direct reversal agent. Now this is a cyclodextrin compound, a big cyclodextrin compound, which is a ring compound. What it does, in its center, it kind of takes away the aminosteroid neuromuscular blocker, particularly your rocuronium. It acts against rocuronium best and second best vecuronium, but it can also act against the other aminosteroid neuromuscular blocker. So it's a direct reversal agent for rocuronium and vecuronium, right? Sugama dex. That's the beauty of the agent. It causes reversal at any time. So if a patient has, let's say, moderate to maximal block, right? Moderate to maximal block, which we can use Sugama Dex for the reversal in a high dose. Like if I have given rocuronium in a high dose and I want to reverse it immediately, I would give 16 milligram per kg body weight of Sugama Dex. I will get an immediate reversal. For moderate block, we give 4 milligram per kg body weight of Sugama Dex. We will get an immediate block. For mild block, we can use even neostigmine as the reversal, and for Sugama Dex, if I am using 2 milligram per kg body weight. Sugama Dex can reverse anytime. So if I want an immediate reversal, I would use Sugama Dex. Neostigmine is also a reversal agent, but it would reverse at a specific time when the neuromuscular blocker is getting detached, and it would reverse only by increasing the quantity of acetylcholine molecule. So how does neostigmine act? Neostigmine act. So this is your nerve, this is your muscle. So what you do, you give neostigmine, okay? So neostigmine comes here and stops the action of acetylcholine esterase, which is the enzyme responsible for metabolizing acetylcholine molecule. So what happened? Quantity of the acetylcholine at neuromuscular junction increases a lot. When the neuromuscular blocker is dissociating from the nicotinic receptor, coming back in the neuromuscular cleft, this acetylcholine, which is more in number at neuromuscular cleft, doesn't give it any chance and go and attach to the nicotinic receptor, and we get a proper reversal. So until and unless the drug is getting detached, neostigmine will not act. So it acts as a reversal agent after some time. In fact, neostigmine is only effective if the block quality is mild, right? If the TOF ratio is more than 0.9, then only we give neostigmine, which will help us in reversal. Sugama Dex can be act as a reversal agent anytime, right? Okay, next question. Which of the following is intravenous fluid of choice in pediatric patient? Crystalloid always. Which crystalloid would be preferred? The most physiological crystalloid, I would go for Ringer's lactate and dextrose if required, right? So for pediatric patients nowadays, we go for a balanced salt solution, always balanced salt solution, which is your Ringer's lactate or Ringer's acetate, even better, with a very small amount of 2.5% dextrose, right? Just for a support, maybe you don't need to give more dextrose, right? So if you want to add just 2.5% of dextrose in Ringer's lactate. This is the fluid which is recommended nowadays for the pediatric patient in perioperative period, okay? Now just dextrose and N5 and N25, these are kind of obsolete. These are obsolete, right? So balanced salt solution, Ringer's lactate plus 2.5% dextrose is what we are using. Now for pediatric patient, the cannula which we are using is 24 gauge, which is yellow, 22 gauge, which is your blue, and your, let's say, sometimes in neonate, we would need 26 gauge, which is violet, okay? So this is about the fluids requirement, fluid in the pediatric patient, okay? But this question is so badly formed, it is very difficult to understand this question. So I am just putting this question so that you give me proper language of this question, because this is not what I am understanding at all anything about the question. All are accepted method of free flow oxygen delivery system. I'm not understanding this question. The language of the question is not clear. So I want you all to contribute in the options of this question so that we can form this question and come up with the answer. As for now, I'm not understanding the options. to go for a proper answer. Maybe little more research, then I would try to find out what was the question asked on oxygen delivery system, right? Okay, so these were the 6 questions. 5 questions I have discussed, which were very simple questions. 6th is not clear. Maybe more inputs from the student side will make the question clear. So this is all about our INI CET latest paper. I hope you had a good exam. Thank you.